Hey everybody, my name is Madeline Stewart and I'm a first year resident. I'm excited to be a part of the ACORE blog series, and today I'll be presenting based off the article Arterial Ischemic Stroke in Children, Navigating Diagnostic and Management Pathways, which was published in RadioGraphics this year. For more details, or if you're interested in the sources used for this presentation, please take a look at my full blog and sources below. My presentation and blog based off of this narrative review are entitled Imaging and Intervention in Pediatric Ischemic Stroke. This narrative review synthesized current literature on pediatric arterial ischemic stroke with an emphasis on early recognition, streamlined imaging protocols, and a coordinated emergency management pathway. Although pediatric acute ischemic stroke is uncommon, it carries a very high mortality rate. It's actually ranked in the top 10 causes of childhood mortality. Pediatric AIS is also associated with long-term neurologic deficits and disabilities. However, its presentation is distinct from adult stroke presentations. Pediatric AIS doesn't usually present with the localizing signs of a particular vessel distribution like we see in many adult patients. Pediatric AIS patients often present with vague, nonspecific signs and symptoms. Because of this, great strides have been made over the past 2 decades in taking great care of pediatric AIS patients. This article focused on recognition, optimal imaging protocols, especially abbreviated MR protocols, and how we can standardize pediatric stroke care as both reasons for the improvements we have seen in the previous decades, as well as ways to continue advancing care for these cases. Some important context to have before we continue on is how AIS is categorized and how common it is. Pediatric AIS is divided into perinatal and childhood subtypes. Perinatal AIS occurs from mid-gestation, about week 20, through the neonatal period, or 28 days after birth. Perinatal AIS accounts for 1/3 of all pediatric strokes. Childhood AIS occurs after the neonatal period until age 18. The incidence in this age group is about 1 to 2 per 100,000 children per year, with the majority of childhood AIS cases occurring before age 5. As mentioned, pediatric AIS is rare and can be very challenging to diagnose. Therefore, sometimes AIS is diagnosed retrospectively, which may impact how we perceive this data. The clinical presentation of pediatric AIS is heavily dependent on the patient's age, and it can vary dramatically. In neonates, seizures are a predominant finding for AIS events, and sometimes this is the only sign that something is happening. Infants that demonstrate an early hand preference should raise concern for a previous presumed perinatal ischemic stroke. This is an example of a retrospective AIS diagnosis like we discussed in the previous slide. In older children, the childhood AIS subtype, acute hemiparesis is the most common presenting symptom. However, other common symptoms that are associated with AIS, like headache, vomiting, or fever, can easily make childhood AIS appear like one of its many mimickers, and this might mislead the health team. The review article specifically mentions the presentation of posterior strokes, since about 25% of pediatric AIS involve the posterior circulation. These patients can present with visual loss, ataxia, or cranial nerve palsies. All of these can be present, or none of these can be present, and that contributes to the subtle presentation of pediatric AIS that we keep discussing. The authors then moved to a learning point that was particularly striking for me: the delays in presentation to the emergency department. The median time to presentation for a pediatric AIS case is about 24 hours. To me, this really emphasizes the subtle, insidious nature of the disease process in this population. It also encourages a higher index of suspicion for both clinicians and parents than I once thought necessary. Now, despite improved awareness and outcomes for pediatric AIS over the past 2 decades, mortality still exceeds 10%, and many survivors face lifelong neurologic impairment. This emphasizes the importance of continued development of awareness, approach, and treatment of pediatric AIS. The article's approach to the workup of AIS is offered here. As mentioned, a high index of suspicion for pediatric ischemic stroke must be maintained. It is recommended to use the NIH stroke scale designed for pediatric patients to help quantify potential deficits you see in your patient. High-yield labs should include CBC, coags, inflammatory markers, and cultures to help evaluate for mimickers like infection and others listed here. And neuroimaging must not be delayed, both to confirm a suspected diagnosis and rule out mimics. Figure 1 outlines the proposed stroke code pathway. First, it starts with the initial triage, which will be a rapid clinical assessment of the patient's airway, breathing, circulation, and blood glucose. If a stroke is suspected, the stroke code will be activated, wherein there is immediate notification of the pre-established pediatric stroke team. As they're coming together, clinical assessment continues with neurologic evaluation, focus history, and obtaining of any risk factors, like if the patient has cardiac disease, infection, trauma, or a history of hypercoagulability. Initial labs are drawn. As we discussed, these include CBC, coags, inflammatory markers, and blood cultures, and then neuroimaging should be done. First line is MRI brain with an MRI head and neck abbreviated protocol, but a non-contrast CT with or without a CTA can be performed if you suspect hemorrhage or if MRI is unavailable. At this point, the diagnosis should be confirmed, and the healthcare team should determine whether it's ischemic or hemorrhagic stroke, and this will determine management. If it's ischemic, initiate neuroprotective measures and determine if antithrombotics or reperfusion therapies are appropriate for this patient. If it's a hemorrhagic stroke, neurosurgery should be consulted. At this point, admission plans should be made, and the patient should be admitted either to the pediatric ICU or stroke unit for further monitoring and follow-up imaging. MR is the gold standard for diagnosis of pediatric AIS, but as we mentioned in the previous slide, there are some situations where CT and/or CTA can be acquired instead. These include cases where there is suspected hemorrhage, when MRI is not available, and even some LVO situations. MRI and MRA are the gold standards because they provide superior sensitivity for detecting early ischemia. They can also be used to differentiate stroke mimics like encephalitis, tumor, or migraine. The abbreviated protocol is emphasized so heavily in this article because it lasts only about 20 minutes and minimizes sedation requirements while maintaining diagnostic accuracy that's comparable to a full MRI. When you consider the patient population and time-sensitive nature of stroke pathologic processes, these benefits cannot be understated. Other imaging sequences and techniques discussed in this section include vessel wall imaging and arterial spin labeling. Vessel wall imaging, just like the name says, helps to delineate specific processes regarding the actual vessel walls, and arterial spin labeling is a promising sequence for assessing the ischemic penumbra. The etiologies and risk factors related to pediatric acute ischemic stroke are complex, diverse, and multifactorial in nature. In fact, about 1/3 of pediatric ischemic stroke cases are idiopathic in nature, where a primary etiology is not identified. However, of those cases where a primary established cause is found, about 50% of them are due to cerebral arteriopathies, and about 30% are due to cardioembolic etiologies. The vasculopathies or arteriopathies encompass infections, dissections, and genetic conditions. These are able to be delineated on the vessel wall imaging sequence discussed on the previous slide. Classic examples in this category include vasculitis and moyamoya. Children with heart disease are at higher risk for thromboembolic events, and therefore AIS. Congenital heart disease, including shunts like PFOs, patients with endocarditis, and patients that are status post artificial valve placement or catheterizations are at increased risk for these phenomena. Another important category to address for etiologies and risk factors include hematologic conditions. These encompass patients that have hemoglobinopathies like sickle cell disease, which actually accounts for about 4% of all pediatric strokes, patients with thrombophilias, and malignancies. In the article, figures 3 through 13 are actually screen captures from imaging studies that demonstrate key findings of pediatric arterial ischemic strokes. Many of these also demonstrate findings of underlying etiologies and risk factors that we just discussed. If you're interested, I would highly recommend checking out the original article for these figures. Treatment for pediatric AIS patients should be guided by institutional protocols, physician preference, and most importantly, the patient's clinical status and comorbidities. The primary objectives of treatment acutely include stabilizing the patient's vitals and doing everything possible to prevent further ischemic injury. Next, you move to neuroprotective measures. And what does that really mean? It means maintaining fluid and electrolyte balances, identifying and correcting any metabolic derangements, maintaining normal vital signs and normal glycemia, and identifying and controlling any associated seizures. Antithrombotic therapy can be initiated once hemorrhage and contraindications like moyamoya disease or recent surgery are excluded. This is commonly done with aspirin or unfractionated heparin. The approach to acute reperfusion therapies will vary by institution. Because much of our current data is extrapolated from adult stroke studies, authorities in the field, like the American Heart Association, cautiously recommend a tailored approach if considering ART. The article specifically discusses the use of TPA and endovascular thrombectomies. Finally, our main takeaways from the review article. Pediatric AIS presentations vary greatly in the clinical setting. Arteriopathies are a leading cause of AIS. Neuroimaging, specifically the gold standard of MRI and MRA, are vital for management. Stroke codes and streamlined pathways can improve outcomes for AIS patients. Reperfusion therapies like TPA and endovascular thrombectomy show promise in pediatric AIS management. Challenges for this condition include that it's under-recognized, there's a lack of standardized protocols currently, and there are data gaps for pediatric treatment protocols. The authors posit that optimizing institutional workflows with a dedicated pediatric stroke code process, coupled with advanced imaging and time-appropriate interventions, can continue to greatly enhance outcomes for our pediatric AIS patients. And that concludes my presentation for this blog. Thank you so much for watching. I hope it gave you a clear and concise overview of my takeaways from the article. For more information and more details, please see the blog below. Thank you.